Hello, everyone. I'm Sarah Vaezi, Providence's Chief Digital Strategy and Business Development Officer, and today's GeekWire studio host. On behalf of the GeekWire team, welcome to today's session, where we will be talking about healthcare and technology collaborating and innovating in the midst and beyond the pandemic and where it may take us. We'd like to recognize the GeekWire members who are joining today. Your membership helps fuel GeekWire's daily journalism covering the Northwest tech community. If you are not yet an individual or corporate member, please go to geekwire.com/memberships to learn more. Today's conversation is part of an ongoing series of virtual events that we've hosted at GeekWire in recent months, featuring top newsmakers and others. Based on today's turnout and the number of questions submitted in advance, I know this will be an interesting discussion, and we wish we could all be together to have in-person discussions. We'll try our best to get in as many audience questions as possible. Please use the Q&A function to submit any questions you have during our discussion. Before introducing our panel, I wanted to thank the Providence Digital Innovation Group for their support as a sponsor of today's session. If you would like, please visit providence-digitalinsights.org to download the COVID-19 Digital Insight Report Series. The Providence Digital Innovation Group is a longtime supporter of GeekWire's weekly podcast, and as part of Providence's nearly 120,000 caregivers, over 50 hospitals, more than 800 clinics serving 5 million patients, we're excited and we continue to meet new challenges and pioneering solutions for the future health of our communities. Now let's meet our panel. I'm so excited to be joined by this esteemed group today, and we'll start today's discussion with introductions, and I'll turn it over to each member of the panel for a quick intro about themselves and their role within their organization, starting with Dr. Peter Lee.
Thanks, Sarah. It's really great to be here. I'm Peter Lee. I'm a corporate vice president at Microsoft, corporate vice president for research and incubations, and so I have responsibility for research at Microsoft, which is in the form of Microsoft Research, which is a set of 8 research labs around the world, as well as some of our larger new business incubations, the largest of which is our health technology new business incubation. So it keeps me busy.
Absolutely. And we've done so much work with you, Peter, so really excited to hear from you today. Next over to Amir Rubin with One Medical.
Hi, I'm Amir Rubin. I'm Chair and CEO at One Medical. So pleased to be with everybody here today. One Medical is a modernized primary care organization that combines digital health and in-person care and testing. Who would have thought any of that would be relevant, right? And we have a membership approach where people sign up as members, either consumers or increasingly employers. We have 7,000 companies that offer this bundled digital health as part of a membership. And then we have these lovely offices by next year in 17 markets across the country. And we integrate with health systems across the United States, such as Providence St. Joseph Health and many others, to coordinate care across primary, digital, and specialty and acute settings. So really pleased to be with everyone today.
Wonderful. Thank you, Amir. And you've also been an amazing partner of Providence. So looking forward to hearing about what you've been up to in this very eventful year. Next over to Julie Sandler, who's a managing director at Pioneer Square Labs.
Hi, thanks, Sarah. As Sarah said, one of the managing directors at Pioneer Square Labs, also known as PSL. PSL is both a startup studio and a venture capital fund located here in Seattle. On our studio side, we work with local entrepreneurs to build new tech companies from scratch. We've spun out 25 companies over the course of the past 5 years, all venture-backed. We've got a team of 22 people across engineering, design, data science, product marketing, ops, finance, recruiting to work with those entrepreneurs to build those companies. And we have our venture fund, PSL Ventures, that invests at the pre-seed and seed stage all across the Pacific Northwest. both in companies that have nothing to do with our studio, and we also do smaller participating stakes in companies that spin out of the studio. Our full team supports both sides, and we've been fortunate to make a handful of investments in companies that have touched the digital health sphere over the past few years, and really glad to be here.
Wonderful. Thank you, Julie. And last but not least, over to Aaron Martin.
Yeah, hi, I'm Aaron Martin. I'm with Providence. We're a large health system based in Seattle. We have about 120,000 caregivers kind of spanning over eight states across the West Coast. Major markets are Seattle, Portland, and LA. And my role is got three parts to it. One is marketing. So the marketing organization reports into me. Our digital team, which also includes an incubator within it, reports into my role. And then finally, our venture fund. So we have a $300 million venture fund with 18 portfolio companies. And I also want to kind of extend my thanks to Peter, Amir, and Julie. They're all really incredible and important partners to Providence. Peter represents Microsoft. We have a strategic alliance with them. Couldn't have gotten through COVID without them. Amir and One Medical were partners in, I think now 3 of our markets, if I'm not mistaken. And Julie is just my sensei in terms of incubation. So I've asked her way too many questions, and she's been incredibly generous with her time. So thank you, all 3 of you, for being willing to participate on this.
Yes, echoing Aaron's thanks. And let's jump in. So considering Seattle was at the forefront of the crisis from a COVID-19 pandemic standpoint in the early stages, what was the initial response like across your respective organizations and businesses? And what were what was one of the key takeaways or learnings that you had as it relates to the intersection of digital and healthcare in response to the crisis? Aaron, let's start with you, given that, a lot of our caregivers are on the front line.
Yeah, I would say one of the things that was really, rewarding, this was the first, kind of crisis in which I felt like, digital kind of could play a part in helping with the situation. During the 2008 crisis, financial crisis, obviously a completely different situation. And so how we kind of addressed it was, early on, we saw the first confirmed COVID case in the United States up in Everett, Washington. And we worked with our chief clinical officer and the rest of our organization to figure out how can digital have an impact in terms of dealing with COVID. And the number one thing that we did first was, as you might recall, we had a massive shortage of PPE, and is an incredibly dangerous environment for our caregivers to operate because we just didn't know the status of people. There was no testing coming through a clinic. And so what we did was we effectively created a digital platform by tweaking and adjusting platforms that we've been working on for years, and working with Microsoft, for instance, on using their HealthBot technology to help people self-assess and self-screen so that they wouldn't show up into the clinics, unnecessarily and potentially spread COVID unnecessarily. And so it was a combination of, a whole bunch of different technologies, including obviously a website to convey information, a self-assessment bot so patients could determine whether or not they're at risk. And then also a video technology that we had kind of built internally called DexCare to help, if patients were at risk, to help them kind of self-assess and see a nurse practitioner quickly. And then we also delivered a remote patient monitoring technology platform for patients who we suspected were under, had COVID, but we wanted to monitor them safely at home. So really kind of each one of those technologies we had in our ecosystem, it was really kind of tweaking them kind of 10 to 20% in the direction of, of dealing with COVID specifically. And it allowed us to scale our response pretty dramatically and protect our caregivers and hopefully protect patients.
Great, thank you, Aaron. Amir, from your perspective as a care delivery organization, how did you all respond? What was it like, and what were some of the things that you learned in the early days?
Well, I learned that we can go faster. I'm not sure the team loves that. I'm like, oh, we can go faster. Wow, we could have 2 and 3 day product development cycles. I didn't know we could do that. But I think a few common points or comment to what Aaron said. We had a platform that was reasonably well suited to dealing with this situation. We had our own digital technology that we've built from the ground up. So we have a member interaction platform, a digital health platform, video and structured messaging and messaging. We had inbound and outbound. We had interfaces with health systems like Providence, two-way interfaces. We had interfaces with laboratories. So actually in the beginning of COVID, I think One Medical had done 2 to 3% of the testing in the United States. Now, we're not that big and there wasn't a lot of testing. The point is we were reasonably well set up to do that. We had to get PPE, we set up in drive-through locations, but anybody can get on the app. And we were able to evolve, in the beginning days, right? We had to triage only certain high-risk groups to get testing. And maybe that was a synchronous video conversation. And then that moved very quickly to basically a questionnaire-like approach with a clinician following up. And then it's like, well, why don't you just self-book wherever you like on your own? And so we were able, even within the first few weeks, we were always we're a very human-centered, design-oriented kind of place. We have a 90 Net Promoter Score, so we're always thinking about the experience. So even in COVID, we're like, well, how do we take clicks out? How do we take steps out? How do we take, burden out? And I think because we had a platform that we can build upon, that allowed us to respond quickly. And I'll also say we've had this concept of interfacing with health systems like Providence St. Joseph Health, because while we think what we do is fabulous, it's not the end all and be all of everything. Some patients are going to need acute care, they're going to need specialty care, they're going to need inpatient care. So being able to electronically make that referral, electronically have that information, and these are things we've been working on prior to COVID, right? And some of it's tech and some of it's relationship, right? You need to know people, you need to know how to work with them. You need to be able to get that discharge information back so you can follow up. So those things were kind of part of our model, so allowed us to respond quite well. And then of course we had, like everybody's teams here, we had amazing team members who jumped in, right? They said, that's great, I'll start swabbing people. Or we knew, and we had people running to Home Depot to buy painter suits because there was no more PPE. And so there's these amazing I call them hero stories of just great people wanting to serve the community. But I think the model and the platform was pretty well to this time.
Wonderful. Those are some amazing stories. And, I know, Peter, you all have been a partner in sharing and building on those amazing stories with providers. Can you tell us a little bit about what Microsoft did in the early days? We've been working with you since March on our COVID response. So can you tell us a little bit more about what you all have done and maybe 1 or 2 key learnings?
Sure. And, first, let me start by saying, thank God for Providence, because it wasn't just having patient number 1, but I still, reflecting back on that, there was amazing vision to understand what was coming just from that first patient. And so, one of the things that happened from that is, you drew us in. And you patiently explained to us what you thought was about to happen, which all came true. And with respect to things like the health bot, that was really driven by you folks at Providence. Obviously, we poured in a lot of engineering support to help accelerate that. But you also then brought in the CDC to make sure that the triage protocols, the self-assessment protocols, would align with the best advice from the CDC. And that had the huge impact of making that HealthBot technology go national on the cdc.gov website and coronavirus.gov website. And ultimately now, I think that HealthBot technology has been deployed at over 2,000 hospitals and clinics around the world. And so it was not just Providence worrying about its own operation. There was this attempt to really have this global impact, which really happened, and it was that sort of example. The other thing that happened also just in the Seattle ecosystem is that first patient was discovered by the Seattle flu study, which is run out of the Brodmann Beatty Institute and UW Medicine, the Fred Hutch, Seattle Cancer Care, and so on. And so that sort of now created a lot of insights and a lot of discussions where we were all learning together. There was a huge amount of intensity to try to understand exactly what was happening and what would be needed. And that sort of got all of us at Microsoft a lot smarter, a lot more quickly early on. And that sort of guided our own policies about work from home early on, where we should be directing resources. We did further work on trying to understand capacity and utilization for PPE, ventilators, ICUs, and so on. And these things, even down to just scheduling software for encounters, ended up being really, really fundamental. It also gave, if you think about a big tech company, people just were wanting to drop what they were doing and respond and help. To give an outlet for those folks, we held a hackathon internally using our hackathon platform. 1,100 employees responded. And now you have the problem, where can they go? What can they do? And it was, working with folks at Providence that really provided some focus where we could really direct people and harness all that energy. So it really had a deep impact. Honestly, I felt like a lot of the projects that we started were going to be summer projects, because the thought process in my mind is we're going to get over this. And some of the team meetings we scheduled just till the end of August. Now we're realizing, unfortunately, these aren't summer projects, and so some of the things that have started within Microsoft are now becoming permanent parts of our company.
Great, thank you, Peter. And Julie, as a company creator and investor, how did COVID impact sort of your initial response and the way you work with your founders and just in general the work that PSL does?
Well, one of the things that I think is starkly different from the ecosystems that we've talked about so far is that the picture for the startup and innovation ecosystem in early spring is very, very different than what the picture looked like in early summer. I'll say throughout, by the way, I think the entire business community has taken just a ton of inspiration from how the healthcare community and particularly local health systems like Providence responded to it. We took a lot of inspiration from how the entrepreneurs in our portfolio and that we saw in the broader community responded to it as well. In March and April, it was blunt force trauma to the innovation ecosystem. Everybody thought, oh my goodness, no one's going to be able to raise capital for a couple of years. We're entering, the dark phase. Almost every entrepreneur I know in Seattle at large started making painful cuts, revisiting their ops plan for the year, gut-wrenching layoffs and furloughs. But painting with broad strokes, by mid-May, the world for startups looked so different than it did for our health systems. For better or worse, the lifeblood of the startup community is free flow of talent, ideas, and capital, and all of those things just rebounded by May, but almost reached a record fever pitch by the summertime. Records amount of capital flowing into our region. Every company in our portfolio raised not only more than they expected, but raised a lot earlier than they anticipated before the pandemic even. So 2020 in every sense of the word has been a roller coaster. It's been a roller coaster emotionally for so many organizations, for their cultures. But even if you just look at the financing trend lines, it's been a roller coaster, and it looks like Six Flags, and we're on our way up right now. So it's been pretty interesting to see that, especially when you know how crippling this pandemic has been for the economy and for the livelihoods of so many people. So there's this very strange duality of the experience right now for all of us in the venture and entrepreneurial ecosystem.
Amazing insights. You know, I heard actually a lot of common themes from the four of you. Amir and Aaron, you both talked about repurposing your existing platforms and kind of creating this foundation for building on top of it. And you all talked about speed and just like that kind of creating an environment for innovation, increased pace of learning, increased teamwork and working together, learning, adapting, evolving very quickly. And then also sort of this notion of like, what we did was not just temporary, but there's like durability and permanence and usability over the long run from some of the lessons that we've taken away from this this really horrible situation, but we can actually kind of use it in the future for our collective benefit. Just really amazing stories from all of you. Now, just with a digital lens specifically, in addition to the obvious, which, you know, everyone is talking about, the adoption of telehealth, which has gone from sort of this this thing that's been limping along and struggling for decades to this huge sudden influx and inflection point really of increased adoption. That's one example of COVID being a catalyst for sort of technology adoption and digital within the context of healthcare. What are some other ones that you think are going to be particularly meaningful? Like what transformations do you think we can expect to see in either care models, business models, technology over the course of the coming years as a result of this pandemic? And are there in particular some technologies you're excited about or you think are going to have really big impact within that context? Peter, let's start with you.
Yeah, there's really, I think, so much that's happening right now. If I focus just first on AI, you know, one of the real needs that came out here that was highlighted by a novel virus, a novel disease, is that in electronic health records there were no codes. You know, COVID-19 hadn't existed before, and so the standard idea that you might just be able to look through electronic health records and understand, like, just answer a simple question like, how many encounters with COVID patients are we having? You know, simple questions like that ended up being really hard AI problems, and so the kind of rise of bringing all of the stunning advances that have been happening in natural language processing to bear on that problem, the amount of intensity in the tech industry that's been happening there, I think is really going to have long-lasting consequences. And then when that has transitioned to an intensity around understanding new drugs and vaccines, you know, there were, under compassionate use provisions, experimental therapies like transfusing people with convalescent plasma from recovered COVID patients. In fact, the largest early access program for compassionate use in the US happened on that. Over 80,000 patients were transfused. And so now the idea of real world evidence, where we should be able to just observe what happened to those 81,000 patients and then extract safety and efficacy conclusions from that. Well, we had a stunning test of our AI and machine learning and data science capabilities to see if we could do that. And while it was successful, and there is now an approved process for doing this, it's an approved therapy, it ended up being a lot harder than we expected. The computer science challenges were humbling at times. And so all of those things just dramatically, I think, accelerated. You just see a different future now about, you know, how all of this is likely to happen.
Yeah, that's an extraordinary example, and we ourselves have used AI in collaboration with you on the chatbot. You know, there are many chatbots that are not necessarily AI powered, but the work that we did with you all on the health bot was yet another example of sort of the rise of those use cases and those real world use cases where we can test and learn and then apply them to patient care or research or other use cases has definitely been accelerated for sure.
Two things that Providence did with their HealthBot technology or drove us jointly that I think have also far-reaching consequences. One is you took the time to try to measure the impact. Like, in what ways was this reducing nurse-centered call volumes or emergency department visits? That's super important, and that closing the loop on that cycle is rare. So kudos to Providence for that. The other is because you brought the CDC in, it forced us to have a standard format for the logic of these health bots so that they could be published as open source. And so now there's an open source foundation, which I think is just super important for innovation.
Great, thank you. Really important takeaways there. Amir, you all are part healthcare delivery, part tech company. You're the definition of that. What have you seen that digital, that COVID has catalyzed from a digital sort of at that intersection, in addition to like the things that we've all talked about around telehealth?
Yeah, thanks, Sarah. I think those of us who work in healthcare or in technology serving healthcare know that healthcare is very resilient to change. And part of it is to make an impact in healthcare, you have to navigate through multiple key stakeholders simultaneously, right? So you have the consumer experience, and that's why you have some great startups. I'm like, oh, we have the greatest consumer idea, but yet the business doesn't work. Well, it needs to be HIPAA secure. It needs to have all these other things. It needs to fit in with reimbursement. It needs to fit in with workflow. By the way, all the physicians work in a different technology, and there would be more clicks. So these are all of these things that kind of innovation in healthcare always, and possibly in any industry, but certainly in healthcare, needs to think about the consumer experience, the payer experience, right? We often have a distinction between who's consuming versus who's actually paying, right? We have the patient, and then we might have the insurer, and then we have a variety of different insurers, be them commercial or employers, for example. And then even within that, you have a separation, right? You have the employer, and then the employer is contracted with an insurance company. And actually, the employer may be self-insured on the business risk, but is using the insurance company as the administrator, the third-party administrator. And then you have governmental payers, Medicare and Medicaid. So you have on the demand side complexity that needs to be navigated through. And then you have on the supply side, if you will, a complexity that needs to be navigated through. We have different specialties. Specialties have their own professional cultures overlaid in top of a healthcare culture. We have reimbursement systems that drive certain incentives. We have organizational structures that make some work easier to do than others to do. And then we're trying to navigate also, if you will, on the supply side, but between an ecosystem of hospitals, clinics, health plans. And so these have always been challenges in healthcare, but I think this is what makes innovation in healthcare and technology innovation particularly, I'd say, interesting, actually, because you can't just pull one lever. You have to pull all the levers simultaneously. And what we certainly saw in COVID was some reduction in some of the friction and barriers that frankly will come back. So for example, people are like, oh, there's been great adoption in virtual care. Well, when you can't go into an office, you're willing to put up with that friction. But it doesn't mean the workflow has been great on every consumer or on the physician for that matter. Now take a physician and their clinics back up to 100%. How many clicks is it going to take them to do that? And what's the path of least resistance? And what pays them the most amount of money, right? And so these are all the things that we have to kind of design around. It's why at One Medical, kind of pre-COVID, we thought about these things and we said, well, then, you know what, we're not going to pay any physician a fee for visit. Because then that encourages a lot of short visits, right, to optimize one pay. So we're going to put them on straight salary. And actually, we can bill for all these on-demand video visits, but we're not going to bill for them, even in COVID. We're not. Why? Well, there's a copay and a deductible that then creates friction to using primary care, which then encourages maybe more specialty and emergency care, which might be higher cost. And we're trying to drive people into primary care. So these are choices, right? They're known. But well, how do you make that work economically then? Well, we're going to charge a membership fee, right? And we're going to try to recover that. And so we saw some of these friction points, if you will, go down a little bit with COVID, but they don't go away. They probably come back. And if you can consider these things and design with these things in mind, one can have pretty powerful impact. So, pre-COVID, we had about 5 or 6 digital engagements per member per year, right? And well, it was one click. Your wait is 1 to 2 minutes. It could be video, but it could be messaging. It could be asynchronous. It could be synchronous. We do outbound digital population health, right? Because it's bundled into the membership fee. The service experience is nice. I kind of like to say it's almost like a staff model HMO in concierge sheep's clothing, right? We make the kind of the best thing to do, the easiest thing to do. And we do the same for the physician, making it the least amount of clicks, the easiest workflow for them. So I think, good design, understanding the multiple stakeholders, understanding workflow and incentives, that doesn't go away, but I think we've definitely moved along that curve, and we've exposed a lot of people, both on the demand and the supply side, like, oh, this can work. Now, how do you optimize this for the economic model, for the workflow, for the interoperability? Those are kind of some of the things we've noticed.
That's great. Thank you. Aaron, I know that Providence has experienced much of the same things that that Amir just described, and we've navigated and tried to simplify the demand and supply side friction and dynamics there. Can you tell us a little bit more, like give us a couple specific examples of what we did at Providence, whether in the context of chatbot or Express Care virtual or video platform, knowing that Providence went from having less than 1% of all of our visits as telehealth, and then suddenly having 13,000, 14, 15,000 visits per day. And just how do you see that? Like what did we see? What did we learn? And how do you think it's going to evolve from there?
Yeah, I think one of the big things that changed during COVID was it felt a lot like the days at Amazon during Q4, except it didn't end. It just went on for like 6 months. And it proved to us that if kind of set with the, to Amir's point, if set with the right kind of motivation, meaning, severe, a huge pandemic and risk for our caregivers and our patients, we can move really, really quickly and deploy technology safely on behalf of caregivers and patients. The other thing that was interesting to me was the borderlessness of organizations. So like I can tell you during kind of the height of us working on the health bot with the Microsoft team, Jean Gabera, who is like my personal hero from Microsoft, she was a part of our team, and her team was basically over at Microsoft working with us kind of 24/7 to ship something in kind of 3 or 4 days to kind of address these issues, because and it was really cool because we were working on teams, and it wasn't, I think it would have been harder in normal times because you have to set up a meeting or go over there, they come over to us and that kind of thing. And it was just a much more fluid interaction with our partners. So that was the other thing too. I think it was also within our organization much more fluid in terms of the way that we can kind of collaborate, across huge distances. I mean, we're in states that are tiny, like, Alaska and Texas and California. I mean, these are huge distances in which we have to kind of collaborate with our our counterparts. So I think that collaboration and that kind of the borders between organizations started to kind of fall very, very quickly to get stuff done quickly, which was really inspirational. In terms of kind of, telehealth, one of the things that we recognized was, and then Sarah, your team led this, was we took a pause and said, how are things going to change in healthcare substantially, based on COVID and from a health system perspective. And the two key so what's that we got out of all that analysis, Sarah's team talked to hundreds of people across the organization as well as across the industry. And the two kind of key kind of business model takeaways that we as an IDN had to kind of face is we're going to have to do two things really, really well going forward. We're going to have to be very, very consumer centric, sort of like, our partnership with One Medical kind of goes to that. And we're also going to have to be incredibly exquisitely good at managing risk and taking on risk, because the two things that are going to happen is, the pandemic did a lot of heavy lifting for disruptors, right? They basically took, the entire population of the United States and said, here, you're going to try telehealth. And guess what? They liked it, right? And so that usually would be a task of a disruptor to kind of, incent, a trial of a new product and get people to use it. Everybody had no choice. And they discovered kind of digital medicine very, very quickly. So we have to get very good at, like, what I would think is like be a retailer in healthcare, right? Have the same types of capabilities from an e-commerce standpoint. So we developed a company called DexCare to kind of accomplish that. And then the second part of what we have to do is we have to align ourselves more closely. We have our own health plan in the Oregon region with insurance so that we can take on risk, because the other big disruptors in the marketplace are the Optums of the world, right? So they're coming in, these big national plans, and they're buying up physician practices and competing with us. And so that is going to push us as an organization to get closer and closer to our health plan to create an integrated experience, so that a health plan member at Providence doesn't have to, today they have to go to the health plan for their health plan information. They have to go to the health system for their clinical information. That's absurd. They should be able to go to one place. There's no wrong door for them to go to find information. So those are the two kind of big driving things that I think are going to impact IDNs on a go forward basis that, really they were trends before COVID, but COVID just sped them way, way up.
Yep, absolutely. And, we've seen similar kind of transformations caused by things like financial crises and other disruptors, like in other industries, for instance, like Netflix disrupting the entertainment and home entertainment industry. Julie, what are, how has that impacted what you're seeing at PSL, whether it be from a specific, like, are there particular themes or areas within healthcare that your founders are more interested in? Are there certain kind of like, is it like home monitoring is suddenly all the rage, or is there something that is really coming out of PSL that you've noticed as a market shift in terms of what folks are focused on, thinking about? And have you all at PSL done anything, like shifted anything to serve your founders, or from an investment standpoint? What have you seen and done there?
Well, so two quick thoughts. First, our Slack channels this morning are exploding with actually a story I think GeekWire covered earlier, an announcement from Amazon that they're launching Amazon Pharmacy, right? Yep. Some folks on this call may disagree, but I think this is a pretty big deal for healthcare. I mean, we've been tracking, at PSL, a number of smaller companies that have been offering online prescriptions, including GoodRx for a while, which Amazon acquired to launch this. But the idea that I can now reliably get my medication within the prime SLA of 24 to 48 hours in 45 states without, having to travel or have my business aired to a bunch of strangers in line behind me who've been there for 30 minutes. I mean, that's big deal, especially for pharmacy deserts across poor and rural areas in this country, and even in urban areas. The idea that, whether it's a pandemic or not, whether it's just flu season, the idea that, I'll be in line for 30 minutes with folks and sharing the virus. It's terrible, right? So this is going to be powerful, and I think net positive up and down the value chain. Thematically speaking, one of the themes we've been thinking a lot about lately is your phone as urgent care. Over the past several years, we've seen phones become obviously de facto medical devices: temperature, heart rate, weight, blood glucose, all your vitals, etc. We're seeing a lot of meaningful innovation, right, in terms of how the mobile device, both with and without external instrumentation, can allow you to self-determine when you do need to escalate to a live appointment. One of our portfolio companies, Alertive, is led actually by former director of stroke at Swedish, Dr. Nirav Shah, focus on collecting data from patients using basic commodity devices that connect to a phone and predict and prevent bad outcomes across heart disease and lung disease, and now even COVID-19. We just met with a brilliant entrepreneur here in town. She's helming a local startup called Wavely, Arna Ionescu-Stoll, focused on ear infections for parents like me that end up having to take their kids to the pediatrician, 10 times a year just to get their ears checked for 2 minutes. Super powerful. And so we've been talking about this device here now for, 10, 11 years as the great frontier in healthcare. I think even more so now, to some of the points that Peter was making earlier around how intelligent modeling can allow for stronger, more predictive insights to allow a patient to decide, can I handle this myself? Do I need to send this data to my primary care provider or nurse? And then beyond that, do I actually need to take time for a telehealth or in-person appointment? And that's a really powerful thing, and arms, consumer patients with a whole new set of tools that will continue to be more important in the coming year. So we're investing in that area pretty actively.
Awesome. Peter, Microsoft has really become a leader in healthcare cloud, cognitive services, health, all of the AI-powered health bot related work. What led to the acceleration of your healthcare capabilities, in particular in the last 8 months or so, which have been very noticeable and really awesome for the industry? And what do you think the future holds looking forward?
Yeah, I think maybe there are two things. It's always hard to know exactly what contributed to what, but we actually, I think, 10 years ago, Microsoft took healthcare very seriously, stood up a healthcare solutions group business, and it, I think correctly, that business looked ahead and saw this consumerization that Julie was referring to, and that is still the future. That is going to happen. The trick always is trying to decide when and how. And it's a little bit like watching grass grow. You turn around and suddenly it's up to your knees. But sometimes you can go for a long time and you have just you don't see anything happening. And so getting that timing right, I think Health Solutions Group in a way was ahead of its time. And in recovering from that and rethinking things a decade later, one of the shifts, or Satya Nadella would say, one of the secular shifts that we're seeing is a desire by healthcare organizations to look at the public clouds, to look at Azure, to look at AWS, to look at Google Cloud, because it's wanting to move away from the hassle of on-premise infrastructure, but also to try to aggregate data for all the reasons that Aaron and Julie and Amir have said. And so then that gets us to ask the question, well, is the cloud ready for that? And I would say 3 or 4 years ago, the answer was absolutely no. We weren't meeting any of the compliance and regulatory requirements. We weren't cognizant of the federal government looking at imposing new data standards, new API framework standards. We weren't taking seriously in our existing products like Microsoft Office, things like Teams, Dynamics, cognitive services, connecting to those data standards. So we just really tried to think, okay, well, let's just make that happen. Can we bake in, understand what's coming down the pike with things like FHIR and SMART, which are now federal regulations, and can we bake them in deeply into the core of our cloud, core of Office, the core of Windows, and so on. And we'll make a shiny marketing pitch and call it the Microsoft Cloud for Healthcare. But in reality, it's no new platform. We're just evolving our core platforms to speak the language of healthcare. And that has been just a very practical thing that's made us interesting to places like Providence and other big healthcare organizations. And then the second element is, I have responsibility for research. And so for our most important customers and partners, like Providence, even they're not all big companies, even smaller like startups like Adaptive Biotechnologies, we selectively offered to send some of our best researchers, people like Jean Gabera that Aaron mentioned earlier, to basically embed and work full time with them, just to get us started. And I think those two things, having a viable platform that actually address the realities of healthcare needs, and then offering selectively our best and brightest to devote themselves to working and innovating together, those got us off the ground. And I think we're just learning a lot faster than we were even just 3 years ago as a result.
Wonderful. We're almost out of time, but I would love to kind of, before we open it up for Q&A, I'd love to get Amir and Aaron, both of your points of view on, we've talked a lot about the consumerization and consumer experience and starting with that experience and thinking about what the market needs and wants. But how, just kind of the other side of the coin, how do you think about technology better serving our clinicians? And in particular, are there any takeaways from what's happened in the last 8 months that have really spurred that thinking? Amir, you referenced a couple different things that you all may have done. I'll give one funny example, which is funny because it's painful in a way and kind of true, is that we looked at an article several months ago that said, the 265 telehealth providers that clinicians need to know. And I was like, how could they know more than 5? And why would that even be of value to them? And aren't we just making their lives more difficult? So Amir and Aaron, from your perspectives, what is the role of technology in making the clinician experience and their lives better? And where do we go from where we are now, and some of the key takeaways? Amir, let's start with you.
Yeah, well, things I used to say, and it still applies, and this is pre-COVID, is we need to make the work experience as good as Peter and the team of Microsoft have made the home user experience. And the user experience in healthcare for the people working in healthcare is not good. It's certainly not as good as consumer grade experience in general. And so in healthcare, we see huge levels of burnout. We have 50% burnout. There's a study in the Proceedings of Mayo Clinic, and they update the study every year. There's a lot published on burnout in physicians, huge levels of burnout. And in primary care, it's about 50% in family practitioners, and a lot of papers written on this, and a few key drivers. One of which is what we call I like to call the burdens of desktop medicine, right? Or as I used to be the CEO at Stanford's healthcare system. One of our great physicians used to talk about it. The Martians came down from Mars, and they were observing healthcare, and they were so impressed by the great care that our physicians gave to our computers, because they would be sitting there and attending to the computer and all this time and not distracted by those patients over there. So, and this is very frustrating because our physicians want to engage, and clinicians and nurses engage with patients. And a lot of our systems, rightly so, are designed to deal with the complexity of documentation and billing and regulation. And none of that's going away. But that creates frustration and burnout in providers. We also believe that the compensation systems and the complexity of navigating across settings are also drivers of burnout. And so we've tried to address those by not only designing a user experience on the technology that's great for the consumer, but also is great for the provider. So we actually have dashboard metrics on the burden of desktop medicine. And I like to talk about this as one used to talk about deficits in the government. Nobody talks about these things anymore, but pay-fors, right? If you want more clicks from a physician, you have to pay for it with less clicks. And we count the clicks, we count the time, we count how many messages come in and hit the provider. And so our machine learning approaches, one of the things they're doing is just using some natural language processing, reading each of those emails that comes into your provider. And we have a lot of them and we allow it unlimited, and pulling it off the providers and rerouting it to our virtual team. So, and part of that's technology, but part of it is we created a virtual team that we call it clinical support. Yes, they're doing patient-facing work, but they're also doing internal-facing work, and we're routing work around our system because a lot of people are emailing their providers about, I need a referral, I need an authorization, can you call my prescription back in? Well, that doesn't need a physician. That doesn't even need a nurse often, right? And so thinking about that burden of desktop medicine, thinking about that user experience, you know, I sometimes like to joke, who likes to go to page 2 of a Google search, or a Bing search, I should say, Peter, right? Like, I'm not clicking on page 2, that's too much work, right? Like, and like, we want providers to prescribe the lowest cost medicine. It's only 19 clicks and you can get to that, right? It's, and by the way, we pay you per visit, you're paid per time, right? And so none of this really aligns right. And so thinking about the provider, the staff, the team experience, as well as the consumer patient experience is well overdue. And it's actually one of the core internal parts of our strategy. We have to make this the best place to work in primary care. Otherwise, it's not scalable, right? You otherwise can't have messaging and video visits, and everybody wants the primary care physician to do everything, right? Manage population health. You know, another example, because we created a membership model, even in a PPO unattributed world, we know who the members are. They don't have to be just in a closed network. So, and then it's pretty easy to apply your algorithms, like who's due for a mammogram, who's due for a pap smear. And we don't have to have the physician look at their panel and have a care navigator call them. That you have in-app messaging and it's all algorithmic. And after I have my visit with my provider algorithmically follows up with me and say, how am I doing? And if I say great, closes out all their documentation and their problem list summary. If I say worse, it goes to somebody else first because they're in office seeing that next patient. So thinking about the user experience for the provider, thinking about the workflow, and then building that around kind of the economic model and the operating model. I think that's the other thing that we've tended to do in healthcare historically is software is built here, administration and financial models are built here, and clinicians are over there. Well, and then that's what you get. And I remember, and I'll stop with this, that my first time a couple decades ago implementing electronic health record, and I'm a big lean and human-centered design person. I like process improvement. And I'm like, well, when do we redesign the process? I mean, we just went from paper and you have this whole thing. And they're like, oh, you'll do that over the next couple of decades, right? And that's in effect what we're left with. We have, we have pretty great technology from great companies. It's just not designed aligned with the processes that we use and the economic incentives. And that's what we try to do. We try to design those three together. And a lot of opportunity there to improve workflow for providers.
Absolutely. A lot of great examples. Aaron, before we close out and go to Q&A, do you want to add any final thoughts on this topic?
Yeah, I think Amir nailed it. The things I would kind of amplify are, so we did, when we did the digital insights reports, one of the things that we looked at was the rate at which physicians, to become compensation neutral, would have to do video visits, assuming just some very, very, small decreases in compensation for video visits versus in-person visits. And it was the most depressing thing I've ever seen, because we went from, kind of 3 to 6 visits per hour, right? And it's just basically saying physicians just you're on that treadmill already, go faster, right? So that is not a sustainable model. And so I think the biggest thing that we can do for physicians and clinicians is have happy patients, number one. So it does feed through that if you have a great consumer experience, it's better than having an upset patient. So let's just posit that. But then more to the point, physicians and clinicians do so many repetitive tasks that should be handled by machines. It is just disturbing, right? And then the third piece to Amir's point is we got to change the compensation system. We have to move these health systems under risk, because that treadmill is basically the fee-for-service treadmill. A lot of those visits don't need to happen. This is a health system telling you that. And these physicians need to be paid based on salary. And then our overarching economics should be paid based on us taking care of the patient versus us, treating people when they're sick or they think they're sick. And then the last point I'll make on this is I was on a panel pre-COVID where I was in a room full of physicians, and it was me and some AI consultant, right? And somebody asked the question, will AI replace what physicians do? And the AI consultant, because this person was in the business of getting AI consulting, dodged around and said, well, no, physicians, they have a special thing or whatever. And I said, God, I hope so. And people were kind of shocked. And I said, if you just do the math on healthcare, it doesn't pencil out. We have to have AI doing a lot of these kind of algorithmically driven clinical tasks where, a woman shows up, in a virtual visit. This is her, 5th UTI. She knows exactly what it is. You could have a machine kind of read that entire kind of patient history. The likelihood that her complaint, which is the next UTI, is very, 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 very high. Today, we make a physician make that judgment, right? Makes no sense. So I think to Amir's point, it's the economics. There's a lot of technology. So we just announced a relationship with Microsoft and Nuance that will make clinical documentation a heck of a lot easier. But we just need to get rid of a lot of these repetitive tasks for our clinicians and our caregivers. It's not the reason why they went to medicine. They did not go into medicine to, to Amir's point, click on things, right? They went into medicine to have that personal human connection with the patient and to heal them. So I obviously get a little worked up about this subject, but I'm married to a physician. My brother's a physician. I hear about this constantly, and I see the burnout that they experience every single day. So anyway.
Well, again, really great examples, and thank you all for an amazing panel. I think we'll open it up for Q&A now, and I'll start with a question. Actually, before I do that, I encourage all of the folks that are participating in today's discussion to please submit your questions in the Q&A of this discussion, and we'll get to as many as we can for the next 20 minutes or so. I will start with one question actually that was submitted in advance, and this was probably the most prevalent theme in what was submitted in advance. But you all actually, Amir and Aaron, you all just referenced the economics and other sources of value. But this is kind of an ongoing question. How do we know that telehealth or AI or other forms of technology are returning value? Let's take telehealth as an example. There have been a lot of conflicting studies about whether it contributes to increase in total cost of care or decrease in total cost of care. And so how do we actually measure their value, and any key learnings over the course of the last 8 months about measuring the value? Julie, since you see a lot of companies, both in the context of the studio as well as from an investment standpoint, how do you see this concept of value generation and returning of value?
Well, on the business side of it, there's two things we're looking for. We're looking for, NPS or some type of customer satisfaction score, as well as outcomes. But one of the challenges that this touches on is just health data, public health data, even through this crisis, is being challenged right now, right? Like when we're reporting on facts, whether it's a particular efficaciousness of efficacy of a service, or whether how our health systems are combating disease, Right now, it does feel as though the way data is being presented and consumed by all the different stakeholders is experiencing a crisis of trust right now. Through the pandemic, I think, the way that data has been presented, should I wear a mask that's made of cloth? Are kids really a vector? Is it aerosol, or should I be afraid of handshakes? I mean, right now, the data that is available openly and being consumed to crunch through all these models is being interpreted so differently by so many different factions. And that's sort of an element of the sensitivity analysis that's become part of our investment diligence process that wasn't in a way before. Is data being presented effectively, and are the people who are supposed to interpret it interpreting it correctly? I mentioned one of our companies, Alertive, right now, and they send a lot of data around blood pressure, pulse, ox, et cetera, to a nurse or to a primary care physician. And, if those data are not being interpreted correctly, or there's something happening in the lifestyle of that patient that the doctor's not aware of, it skews results, it skews outcomes, and it certainly, changes those satisfaction scores. So that has taken on a whole new meaning throughout the pandemic, and it's a question that's top of mind whenever we look at a new company these days.
Awesome. Peter, how about from the Microsoft perspective? You talked about AI and other sort of technology domains. How do you all think about the value that is being returned by technology?
Yeah, I think there, just maybe to touch on something Julie just said, but before that, what Amir and Aaron were talking about, one of the major business propositions or value propositions that Microsoft offers to enterprises is in productivity improvements. And generally speaking, when we enter into a commercial agreement, with an enterprise customer, we actually go through an exercise to calculate ahead of time the return on the investment in our technologies, if deployed, and then we track that, after the deployment. And in fact, sometimes that analysis says, oh, actually, if you migrate these 8 applications to the cloud, it'll actually cost you more money, not less. So we're not going to do that. We'll focus on these other things. And so that is sort of the expectation of all major enterprises when they enter into business with Microsoft. And so from that lens, we try to go through the same process. So for example, when we're talking to Aaron and team at Providence, we try to go through that same process. Now, the challenge there is there are so many more unknowns. To give you one example that was actually painful in the early weeks of the COVID crisis, Aaron made mention, well, where's the PPE? Well, tracking that is not in the electronic health record system. It's partly in some combination of ERP systems, but those ERP systems are different across their 50-odd hospitals. And so it suddenly became a very complicated data plumbing issue to try to solve these things. And so when you have that level of the kind of complexity that Amir was speaking towards, in fact, I make a bad joke. The Nobel Prize winning physicist, Richard Feynman, once famously said, anyone who claims to understand quantum mechanics doesn't. I sometimes feel like anyone who claims to understand how the healthcare business works obviously doesn't understand it. And that complexity just makes it very hard to do Microsoft's normal business practice with enterprises to calculate ahead of time that there'll be a positive ROI. Having said that, the leading edge organizations, the ones that are really progressive, like Providence, they're going there anyway. And so, I think my view is we're all having to learn together, what works and what doesn't, what pays off and what doesn't. And I think we're all supremely optimistic that it's going to, broadly speaking, pay off. But if we're really honest with ourselves, we actually don't really know yet.
great answers from both of you. Thank you. I'm going to switch gears a little bit just because, again, another sort of a different theme that was submitted in advance, and we've got a question in the Q&A today as well. How do you think the healthcare ecosystem, in particular providers, but we can think more broadly than that too, should be preparing for and proactively responding to disruption, and kind of going to that concept of speed that we talked about at the very beginning of today's panel? How can we actually accelerate the velocity by which we are innovating to be responsive and proactive and ahead of the curve, as opposed to always sort of behind it and dealing with this, as you described it, Amir, resilience against change. Maybe, Amir, I'll turn it over to you. What do you think we need to do to speed things up a little bit more even?
Well, in healthcare, we're always about 100 years behind on kind of the corporate strategy. We've just discovered vertical integration in healthcare, and we've decided that we should vertically integrate from rubber manufacturing to tires to wheels to the combustion engine to the automobile and own the dealership. And that unless we vertically integrate, and we do it on a single platform, single ERP, if you will, platform, that will be the innovative way to move quickly and respond. That's kind of what we've been doing in the last few decades in healthcare. A lot of industries have moved off of that and talked about, well, maybe it's API based, maybe it's networked based, maybe it's cloud based, and clearly there's room for all of these kind of corporate strategies, and there's logic behind them. But I think one needs to have a corporate strategic belief that a networked approach, cloud-based, if you will, API-based, and I'll use those as analogs. It doesn't have to be just in technology. It can be, it could be a manual relationship, is relevant. And I think, that's what gets me excited about kind of the panelists here and the work they're doing, and Sarah, the work that you're doing, and Aaron and others at Providence. Like, you've built a whole team and department just to do that, right? Like, even as you have physician offices, hospitals, and health plans, you are vertically integrated, but you haven't stopped there as well, recognizing, and frankly, you've partnered with folks like One Medical. And to me, the leading health systems and healthcare organizations have always been ecosystems, right? Many of your physicians still are in private practice. Some are employed, some are affiliation, but these were always ecosystems, right? There was always alignment. There was, and they've gotten tighter connected, and I think in general that's been good. But it's hard to move quickly and be responsive. So I think it's building those connection points. It's building those APIs, if you will. It's building the willingness to develop those relationships, knowing that that will grant you flexibility and speed, and potential, degrees of freedom and innovation that you might not on the existing chassis. And nothing wrong with the existing chassis, and one should continue to innovate on that. And sometimes then these kind of things at the periphery, bleed over into the existing chassis. Sometimes they become core parts of the existing chassis, but it's a recognition, I think, of being an ecosystem. Like, what do you want to be? I want to be the ecosystem, right? Like, or that's what you all are doing at Providence. At One Medical, we're a small part of that ecosystem. But on the flip side of that, we know, as great as we think we are and as fabulous as what we do, if we're not part of insurance, if we're not connected to employers, if we're not connected to hospitals, if we're not connected to specialists, this goes a little bit to your last question of value. Do people need a bunch of urgent care fee-for-service virtual visits charged to their insurance company? One could debate. NPS could be high. There's value in that, but like, does that transform the U.S. healthcare system? I don't know. I mean, probably not. Practically speaking, that was probably coming anyhow. But if you can do that and coordinate with your specialists and then follow up post-discharge and avoid a readmission and then risk stratify and follow up in gaps in care and then improve health outcomes over time across multiple geographies, across multiple settings. Oh yes, and also demonstrate you can take out cost. That's transformative. I don't think we can get there without the technology, but it requires a mindset of thinking about what's the ecosystem like in a different way. And that requires, it requires boldness and investments, right? You in your role, Sarah, you're at the center of this, right? Your organization decided to invest in that, spend money in that, and that's a longer term play sometimes. Now, boom, pandemic comes along. Brilliant, right? Brilliant corporate strategy. You had that in place. But, it took investing in that in advance. And healthcare takes investments. It takes those risks. So yeah, some reflections.
Great. Yeah. I mean, I think I heard a couple key kind of takeaways. The funding needs to be there. The leadership needs to be there. The structure needs to be there. All of these things kind of work together to create the conditions that are right for increasing the speed and enabling innovation. Aaron, what else would you add to that just from a Providence perspective?
I would just highlight a really important concept that Amir brought out, which is, and Amir also comes from running a health system. So like, it's not surprising that he called this out, which is, we need a flexible ecosystem, because IDNs are not a business, right? We're not in the health system business, right? We're a collection of many, many smaller businesses. The problem is our ecosystem is incredibly brittle, right? So it is not flexible. It's not API driven, to Amir's point. And so what does that mean for an IDN? It means we have got to build partnerships like we have with Microsoft that kind of increase our agility, right? So that we can kind of start plugging in other interesting partnerships like what we have with One Medical, so we can attach them to our ecosystem, right? Right now, it's incredibly hard to do those things. And it's absurdly hard relative to kind of other industries, right? The amount of time that we spend kind of integrating new partners, my friends from other industries are just baffled, as why it would take that long, right? And so that's an indication of the brittle nature of kind of our business processes and our technology. And that's the key thing that we've got to change as an organization. And then the other thing I always talk about is to other IDNs who will listen, is we're out of time, right? So like, this is not one of those typical scenarios where you can take 10 years and figure it out, right? Like, the strategic planning process is like, we're now, kind of swimming with the Amazons of the world who, they get things done in weeks and days, right? And so we need to start moving on, at that pace very, very quickly. And so I think the pace of innovation has got to change dramatically for health systems. And I'm a big believer, there's a reason why I came from Amazon to a health system, because I believe in the fundamental value proposition of a continuity of care, right? I think that saves money and it improves outcomes over time. And I'm a big disbeliever in the fragmentation of care. That's one of the reasons why we partnered with One Medical, because of that continuity of care. They provide excellent primary care, and we kind of provide to their patients, if you will, this big kind of back-end infrastructure around specialty, anything that can go wrong, we can deal with, right, with those patients. So that continuity of care is sacrosanct. And so, to kind of, keep pace with all the different innovations going on out there, we have to make our ecosystem much, much more flexible and adaptable. And we need to partner very aggressively with other companies.
All really, really great points. We're almost out of time, but I wanted to hit on one final question that was that came up a lot in the pre-submitted questions, and it's this notion of health equity. And when we're trying to move fast, when we're trying to generate value, when we're focused on sort of business drivers, those kinds of things like health equity can sometimes take a backseat in a really unfortunate way. And there's a lot of well-documented studies now that demonstrate that technology can actually contribute to a digital divide and increasing disparity. So just with the final moments, I actually wanted to hear from all of you, and I'll start with Julie. How do you think that you all can address and factor in health equity in terms of the technology and services that you're providing to your communities?
Well, the term health equity can be interpreted in a lot of ways, and I'll choose one, which is the amount of research that is done, available, and channeled into solutions and products for women. There is a very interesting category of investments called femtech, or whatever you want to call it these days. And a lot of firms, a lot of venture firms that invest in companies that fit in that category are generalist software firms. And one of the challenges for that category, and also in general to achieving even just gender equity and the amount of knowledge and research and solutions that are out there, is the fact that a lot of those companies sell into health systems. And if I'm a VC and I invest in software companies, and some of them are selling into, the CIOs of big companies, or someone who's selling into a health system, unfortunately, there's much higher hurdles for your average femtech company to clear, because sales motions are longer and more friction filled. Decision makers are not always empowered at a single point of buy. You have the fact that a lot of healthcare systems are slower to move. And so I look at health systems like Providence. There is a deliberate and clear willingness to experiment at the top, to take risk. And even, in my conversations with both of you, Sarah and Aaron, like a willingness to fail and start anew. And that ethos at the top of health systems is so critical to companies in these emerging categories to actually pick up steam, and to folks like our firm saying, maybe there isn't too high a hurdle for us to make that investment. And that's my great hope for companies emerging in these spaces. And you could say the same thing about companies that focus on minorities, different parts of the country that have less access, different parts of the world. That is such an important element of the equation here. And it gives me a lot of hope and heart to see what health systems like Providence are doing to ensure a smoother process and the explosion of more companies that are speaking to these really critical aims.
Awesome. Thank you for that. Peter, I'll turn it over to you. How do you all think about health equity? And, AI is one example where that can become an issue in terms of the algorithms and potential bias and controlling for those things. But are there any other particular, either in that kind of area or in other areas where you think there's real potential for technology to actually positively impact and support health equity?
It's such an important question. It's a real area of concern as we're trying to think about, how we operate in a capitalist, world and society with more of a conscience. And, particularly with AI, there's been a huge effort, not just at Microsoft, but across the tech industry and in academia, to try to understand the propensity towards biases and lack of transparency in AI systems, and also, as a practical matter, how we create more accountability there. But if one of the things that has been most transformational for me personally in my work with Jim Weinstein and others is Jim's famous phrase, "Zip code is destiny." And this was something that came out of something called the Dartmouth Atlas that really looked at, for example, at how long people live on average based on the zip code that they live in. And it's shocking just to see the disparities. Even in adjoining zip codes, there can be 10, 12, 15-year differences. And when you try to zoom in on these things, the Dartmouth Atlas work, I think, as one of the prominent population health studies, did some amazing, drove some amazing insight and impact. And yet, from a computer science and machine learning perspective, that type of data analysis today could be done with tremendously more sophistication. We aren't limited to just simple histograms anymore. We can do predictions, we can do forecasting and trends analysis. And that, at least from a data perspective, would help give insights on where we should be focusing attention to address disparities, and as opposed to just looking at things retrospectively. So that hopefully could be a contribution, but the thing that we know already from the data is there are just massive disparities, and it's something that absolutely needs to be addressed.
Another really amazing example. Thank you, Peter. We'll close it out with Amir and Aaron. Amir, I know you all have a very interesting sort of membership model, which does focus more typically on folks who can afford higher end services, but how do you all think about health equity in the context of One Medical and how you can support communities?
Yeah, actually, it's the exact opposite. We focus on everybody. For $16 a month, you can have unlimited digital health, and you could be uninsured. We accept in exchange. We set up COVID testing in every borough in New York City. With the mayor's office, we were the only one outside the health systems. We made our membership free to everybody, and you didn't have to line up in a long line. You just got on the app, you booked it, you got your result, and if you had any questions, you talked to a provider, and there's no fee. And for those folks, we made the membership free. They didn't have to pay the $16. But that's a lot less than your copay and deductible, whether you're on Medicaid or Medicare. So actually, it's a much lower cost model, and is we see it being applicable broadly. But to your really important question about diversity, equity, and we call it inclusion, and also justice, I think a few things that we're doing. First of all, is how do we try to have a representative workforce? And so great. So we are now 45% non-Caucasian at One Medical. We're 70% women, including in our physician ranks. And that's been intentional, and it's something we work on, and we have a lot of work to do, and we're far from where we need to be. But let's get diverse viewpoints working on everything and get them on the team, rather than have a lot of the rest of us saying, I wonder what a diverse viewpoint might be on this topic. And we think about that in our care too, and in our both our member base and our care team. So we've launched behavioral health solutions, kind of virtual solutions, virtual coaching and behavioral. We have group programs for LGBTQ+, led by LGBTQ+ providers. We have effectively 100 NPS score on those groups. Like, everybody's like, this is so amazing. I've never been able to talk in a group with somebody who's just like me. We did the same with our Black providers and are launching those programs for our Black members. When we think about our external PR and who we're putting on TV or media, we're trying to get exposure to different team members there. Certainly in our software development team or our AI teams, thinking about that as well. So just trying to, be representative in our team, and then trying to give opportunities. A lot of our folks we've hired, particularly I'll say at the front desk level, have never even worked in healthcare. We've hired towards attitude orientation and frankly service orientation. We have several of our VPs who came in from those positions. We've created internship programs for BIPOC high school students and underrepresented communities, just to get them exposed to tech and healthcare. And it's super rewarding internally. It's been fun. We've done the same in an internal mentorship program for our team. So those are some of the ways we're thinking about this. And then, of course, learning from other great institutions, what's out there, what can we learn? And then finally, we have a whole medical advisory council on, we used to call it culturally competent care, but now we call it health equity. But let's train our providers on, spotting melanoma if somebody has dark skin, right? Or that's different. And not everybody has the clinical expertise or training or comfort. And so we have our weekly grand rounds, we have our educational sessions, and now we have a whole team of people, and that's what they do. And their job is to curate the medical literature, to then educate our team members, and then we have to look at it in our metrics. So we run metrics, we run NPS scores, we run quality scores, and we run that by, different metrics, including race and ethnicity and sexual orientation and gender identity, and see if there's variation, see if how that information looks, and then respond to that. So those are some of the things we're thinking about.
That's awesome. So heartening to see folks actually doing so many of those really important things. Well, with that, Aaron, I'll hand it over to you for any closing thoughts on this topic, and then we'll wrap up for this session.
Yeah, I mean, one of the things that I love to kind of point out is we believe we're the oldest organization in the United States founded by women, and so we have an incredible, and I think we beat the Red Cross by about 10 years. So, and we have an incredible tradition of women leaders. On my team, for instance, most of my directs are women. And the reason why that's so important for a health system is because, 90% of decisions made in a typical household are made by the woman in the household. 70% of our workforce are female. And so it's kind of crazy if we don't have, the folks building solutions, being represented. That's the first thing. The second thing is, when you go below my leadership team in digital, it is not the same story. We have a lot of work to do, especially in engineering. Software engineering has traditionally been kind of a hard part of the organization to kind of get to kind of a 50-50 split. And we're working really, really hard on that as well. And then finally, in terms of, health disparities, Rhonda Meadows, if you ever get the chance to meet her, see her speak, be in the same zip code as her, you should take that because she runs population health, but she's also leading our health disparities work. And one of the things that she will point out is COVID has exposed how incredibly horrible health disparities are in the United States health system. And we need to do better as an industry. And it just kind of points out all the weaknesses in terms of, caring for the underserved and the vulnerable. And a lot of the really exciting work that my team does that they get fired up about. And Sarah actually was very instrumental here. I'm going to brag on her here in a minute. In terms of our hackathons, we're building, new technologies to kind of address health disparities. So for instance, we used Microsoft technology to work on kind of reaching out to people who English is not their first language, multilingual translational services, through video, which is magical to see that happen, so that you're doing a video visit and it's being instantaneously translated from English to whatever language that person speaks and selects, as if you're watching a really well done kind of captioned Netflix video in real time. So those types of things, I think digital can have a huge impact in terms of increasing access and lowering disparities and outreach. But the key central thing that we've got to do as a team is make sure that the team that we've got looks an awful lot like the team the patients that we serve. There's just no getting around that. And we've got to Amir's point, we can't wonder what it's like. We have to have people on the team experience that, day in and day out, so that they can start coding in the right direction and helping us kind of move our products in the right direction. So, my team is very passionate about this subject, and we're really, really fortunate to have Rhonda Meadows as a partner kind of help us kind of lead us down that path around how we can address disparities in care.
Wonderful. Well, thank you all for your thoughtful answers about that last question, but also just in general today. I feel so humbled and privileged to have spent the last 90 minutes with you and hearing your insights. So thank you for joining us. And thank you to everybody who joined today. We look forward to seeing the rest of your questions as well, and really and sincerely appreciate everyone sharing this time with us today. Before we go, I also wanted to invite folks today that have joined this webinar for an upcoming webinar on December 2nd, which we're calling the New Healthcare Imperative, Optimizing Access Across Business Lines. And I will be joined by innovators from Kaiser Permanente, Houston Methodist, Community Health Network based in Indianapolis, and others to discuss a new type of infrastructure that orchestrates health system capacity and digital demand across all lines of care, and is really instrumental for all of us in terms of new models of consumer access, navigation, and optimization of supply and demand, topics that we hit on briefly today as well. We'll get a sneak peek during that conversation of a company that we've incubated within Providence called DexCare, and we encourage all of you to register if you're interested. You can go to go.xtelligentmedia.com/2020-12-2 DexCare webcast _unique. That was a lot of URL for me to describe verbally, but thank you again for everyone for joining, and again, thank you to our panelists. Really looking forward to all the innovations that you all will be setting out into the market in the coming months and years, and thank you again for your contributions. Thank you everyone for joining.